So my assessment is really more complex because we're trying to look at you as a whole. So you might come in for hip stuff, you might come in for low back stuff, you might be coming in for pelvic floor stuff saying you're leaking or having issues with bowel movements or pain with certain things. Then I'm not just going to be looking at pelvic floor, I'm making sure I'm looking at the whole picture. So I'm looking at sleep, I'm looking at diet, because all of that's going to impact the tissue, and that's all in my intake. So my intake is about 17 pages long. I read the whole thing, and it's because I want to know the whole picture of what you're experiencing. And then after I read through that, then the true assessment component is me having the person walk, because I want to see what are the feet doing with the knee, with the hip, with the back, with the arms, with the trunk, with the neck.
Welcome to Harmonic Alignment, a podcast that explores the new frontier of energy medicine, bridging the gap between Western medicine and quantum physics, giving you easy and practical solutions. Guided by me, Dr. Larisa Sharipova, and me, Priscilla Koblenz. Join us on a journey discovering your harmonic alignment. On today's episode of Harmonic Alignment, Understanding Your Pelvic Floor, Dr. Larisa Sharipova sits down with the amazing Dr. Becky Quintangeli. Dr. Becky is a physical therapist and the director of women's health at the Movement Paradigm. She tells her story of her own health journey and understanding the pelvic floor, and that it isn't just about women who've been through childbirth, but it can affect all of us. It not only affects your urinary and your bowel movement health and your ability to have pleasurable sex, but it can affect your lower back and your hip pain and even how your foot hits the ground. This is such an important conversation, and it's one you're really going to want to share because, frankly, how many of us have been taught to poop correctly? You're going to love this episode. Reserve your spot today on the Tuscany Transformation Retreat, June 15th through the 21st, 2025. Reconnect with your inner beauty, power, and abundance. Come join Dr. Larisa Sharipova and myself, Priscilla Koblenz, for 6 nights and 5 full days in the beautiful Tuscan countryside. We'll be staying at a villa that has a gorgeous swimming pool and hot tub, a Turkish bath, as well as this amazing yoga studio overlooking the olive trees and the vineyards. We'll offer daily yoga, meditation, breath work, sound healing, spa treatments, a Tuscan bike ride, a pasta cooking class, olive oil and wine tastings, as well as amazing, amazing food. For more detailed itinerary, check out our website and reserve your spot today. We've got 9 spots available.
Hello everyone to our Harmonic Alignment Podcast, and today I interview Dr. Becky. Welcome to our show.
Thank you so much for having me. I'm so excited to share about the pelvic floor.
So, interesting topic today, and as a trained OBGYN, I'm very passionate about the topic, and we know that there is a lot of things that can affect pelvic floor. But my question is why you were interested in pelvic floor therapy.
Yeah. So I got into pelvic floor PT actually well before I even did PT school. So my son was born very chaotically. He was an emergency C-section, came 2 weeks early. And because he was an emergency C-section, I did not have an epidural, which meant I had to go completely under. So I remember I was having contractions and I was like, oh, no, it's so painful. Woke up and all of a sudden I had a baby on my chest and was like, what just happened? So that was really traumatic for me. I felt like my voice was not really heard a lot within that realm of things, which was really, really difficult for me because I woke up on a morphine pump on top of all of it too, which I didn't want a C-section and I didn't want to have a morphine pump, and that's exactly what happened. And then I remember when I was about to leave, I saw my doctor and she was about to discharge me from the hospital. And I said, hey, I would absolutely love to get screened from a pelvic floor PT. Is there any way that I can get a script for that? And she said, well, how about when you come back to your 6-week appointment, if you're still having issues, then we'll go ahead and write you a script, but here's some opioids for you. And I was like, oh my gosh, this is not what I wanted at all, the complete opposite. Fast forward, I went to my 6-week appointment and I said, hey, I just really want to get a screen, just make sure everything's good. I know I didn't have a vaginal birth, but I still really want to make sure everything's okay. And she said, well, if you're not having any pain, you're not having any leaking, you're not having any discomfort, then you're fine. Go ahead and just go about your day.
And come back when you have a problem.
Right. Which kind of blew my mind because I was trying to be preventative and I just felt like it was totally getting dismissed. So fast forward, I ended up going to my interview for PT school when my son was 6 days old, got into PT school, started when he was 4 months old, then was exposed to pelvic floor PT. And I remember raising my hand and I was like, hey, I want to be the dummy. Please use me as a test dummy. And they were checking for diastasis recti abdominis, also known as DRA. So it's that laxity within that center line. And it happens mainly to women after pregnancy. It can also happen to obese men. It can kind of just happen from poor mechanics as well. And I remember when she tested it, we just felt her hand just keep going further and further into my abdomen. And she goes, hey, does everybody want to see what a positive test looks like? And so at that point, my son had been about 1.5 years old. And that was what I didn't want to happen. I was trying to prevent that. And I couldn't figure out why I couldn't lose weight, why when I worked out, my back hurt so bad. And I was like, wow, this all could have been prevented if I had that script. So just from the pelvic floor realm from pregnancy, that was my main thing. But then also when I was in PT school, my mom was diagnosed with endometrial uterine cancer. And I watched my poor mom just get bounced around from appointment to appointment to appointment. And she never even went to pelvic floor PT, never even dealt with any of those things. Now, she definitely had symptoms of leaking and she had hip pain. And they just kept sending her off to an orthopedic PT, which is fantastic. But they never screened her pelvic floor, which could have been contributing a lot to her hip pain and discomfort. And that's when I realized I need to come into this field to be able to advocate for women so that they know what signs and symptoms to ask and look for so that they can hopefully do more preventative stuff and then also be able to advocate for themselves when they are having pain and discomfort, to look at the whole picture.
A few questions. What do you think was the reason for emergency C-section?
So I actually think it was probably divine intervention, to be honest, which is kind of crazy. The whole pregnancy, I was healthy, I was good, no issues. I remember I went into my appointment that Tuesday and I wasn't feeling well. And I said to my doctor, I was like, I feel horrible. I feel so sick. And she was like, you're fine. This is totally normal. Now it was 2 weeks from my due date. It was around the holidays. And so we just thought that I picked something up from being around everyone. I also had gained a lot of weight. So I think that kind of complicated a little bit too. And I remember going to the pharmacy with my husband and she had given him a list of things that were safe for me to take so that I could just function because I was still working at that time. And my husband's walking around and I'm just hanging on all the shelves. I'm like, I don't know why I came in. I feel horrible. Why did I do this to myself? And we got home and I remember I started to kind of feel like I had contractions, but I thought it was Braxton Hicks because it was my first kid. And my husband was out working and I ordered a pizza because everyone always says once you get to the hospital you can't eat. And I was like, I want to eat before I go in. So I ordered pizza and water ice. We pick it up. And I looked at my husband and I was like, I think that something's really wrong and we need to go to the hospital. And he goes, who orders a pizza before they go to the hospital? I was like, I just really wanted to eat. So I called my doctor and she asked my husband to take my temperature and I had like 102-degree fever, which is not safe at that point. So I just had to go in and they put me into triage. They tested everything. Everything came up totally fine. And they were handing me my discharge papers and I projectile vomited everywhere. And my husband even looked at me and goes, I've never seen that. And we've been together now for 16 years. And so he was like, wow, I don't even know what's going on. And so we're like, well, you just admitted yourself for the night because if you're projectile vomiting, we need to figure out why. So they got us into a different room. They had just swabbed me. And in that moment, they swabbed me, they left the room, my son punched my water bag open. My husband jumped up, he was like, what was that? And I was like, I don't know, but I'm peeing myself, I think. And then I realized, oh my gosh, it was my water, it broke. So my husband ran out and said, hey, her water just broke. And they're like, no, we just swabbed her, she's fine. He's like, no, I heard it, I'm telling you. So then the nurse came in, and as soon as the nurse walked in, my son's heartbeat just stopped. Like there was nothing on the monitors. And then she's pushing on my stomach, trying to get him to move or trying to rotate me. And it took too long. The heart rate was still gone, and they just rolled me into the OR. So from the time I got into the room until I was in the OR was less than 10 minutes. They pulled him out, and the umbilical cord had been wrapped, which is really common. That's not an uncommon thing. It would have taken us at least 45 minutes to get to the hospital because it was that far of a drive. Because where we lived, the hospital didn't deliver, so we had to drive 45 minutes. They said that it probably would have been a different outcome if we had not been admitted. So I really think someone was just looking out for us. I mean, my birth was so traumatic. I had to go to so much therapy after all that too.
And you have only one child?
Just one. Yeah.
Sorry about your experience. And how is your child doing now?
Great. We went to one of his soccer games this morning. He is a very athletic kid, very involved in a lot of sports, absolutely loves school, and so no issues. It did not impact him at all. Yeah.
Great.
I know. Very lucky.
Yeah, you were lucky that you were in a hospital and could save your child. So why you were interested for yourself about pelvic floor at that moment? Why it was in your mind that you need to do something about that?
I always believe in preventative medicine. I don't think that we should be looking for symptoms to then treat. I think that we should be trying to get ahead of things. And I just knew I wanted someone to just screen and see, is my pelvic floor okay? Is my abdomen okay? Is my scar healing up okay? Because it was an emergency. So what kind of things came from that? And I did not go to therapy until my son was about 5. And I think if I had been with someone who had heard that, because that's what I do for all of my patients, I always check in on my moms. How are we doing? Have we talked to someone? And just try to make sure that they're referred to the right people. I just feel like a lot of things could have gotten the ball started a little bit sooner, but just I love preventative medicine. That's my favorite thing, and that's what I was looking for.
So let's talk about pelvic floor. A lot of people probably don't know how it look like, where is it?
Yeah.
So explain what's the pelvic floor is.
Yeah. So for everyone who's watching, I have a diagram. I have my pelvis here, and then for everybody who's listening, I will just describe it for you as well.
Where to find it on the body.
Yep. So the pelvic floor is, if you're sitting in a chair right now, it's the muscles that are in between your sit bones and then where your tailbone is and your pubic bone. It's that whole circular area underneath there. So the pelvis, for everybody who can see it, is divided up into 3 layers. So layers 1 and 2 is more towards the front. I'm holding only one layer here, but that second layer is kind of deep within that first layer. This first layer and second layer mainly deal with your bladder health, little bit of the bowel health ends of things, and then for females also vaginal health as well.
And that's muscles.
Muscles, you got it. And so those muscles for the front pelvic floor, you can see run more of like the side to side, so from hip bone to hip bone. And then the third layer, the deeper layer, is more bowel health ends of things. That runs front to back, and it's going to run kind of right into that tailbone area. So a lot of times when people have tailbone discomfort or even SI joint pain or low back pain, it's because these muscles are so tight that it's pulling on those structures, creating that discomfort for people. That's the reason why you want to screen for low back, for hip, and pelvic floor, all 3 of those, no matter what someone's complaining about. So just these muscles kind of sit on top of each other, and they work together to create a lot of stability. And then it also holds all the organs up that are in the space above as well. So these muscles are extremely important. And then on top of these main muscles, we also have wall muscles of the pelvic floor. So everybody's always heard of piriformis, maybe piriformis syndrome, sciatica, those types of things. That's actually a wall muscle of the pelvic floor. And then another muscle, our obturator, internus specifically, that one is also another wall muscle. And then also those are hip muscles. So that's the reason why we want to screen the hip when we're looking at the pelvic floor as well.
And those muscles are inside of the pelvic bones?
Yep, they're sitting inside that space. Now, the front pelvic floor, you can see sit on the rim portion of the pelvis. So when you are sitting down, you can't really feel it because you have a lot of fatty pad in that space as well. And they're deeper muscles. They're not really so much superficial, except for mainly like that first layer, layers 1 and 2. If you were to kind of feel around down there, you are touching the flesh component, but right underneath that flesh are going to be these muscles as well.
So let's talk about what can cause dysfunction of pelvic floor.
So many things. So everybody always thinks that it's just stuff that women deal with. That is a myth. That is not true. I work a lot with men as well. Mainly when it happens for men, it's after they've had their prostate removed, because now they've introduced scar tissue into the tissue of like where they were having some support. Whereas women, unfortunately, always have that because we have the vaginal opening. So we have one extra hole compared to males. So that's the reason why women tend to be the ones that everybody's like, oh, that's who experiences it more. But men will have it sometimes after prostate removal. They normally, unfortunately, don't get enough care. They really don't get referred off to pelvic floor PT. I would always recommend for anyone who is a male going to go through that process, do pelvic floor PT before as well as after, because it will cut back the time that you're dealing with your symptoms.
Why it's important to go before? What does it do to prevent the dysfunction after surgery?
Prehab is kind of like a really common thing that people think about for when they get their knee replaced and their hip replaced and sometimes their shoulder, but people aren't thinking about it when it comes to the pelvic floor. No one connects to their pelvic floor because it's a space that's almost a no-no. Like we don't talk about it within society. There's so many commercials out there where they're like, we have to sing about it because we don't want to talk about it.
And we use different words that are confusing for people.
Right. I mean, just use the anatomy. It's okay. It's not a bad thing. So most people don't even know how to contract their pelvic floor appropriately. Or they're over-contracting in either the front of the pelvic floor or in the back, and it's actually very dysfunctional. That's not actually doing the right thing for the pelvic floor. It's going to create tightness, and then it's going to create weakness within the pelvic floor as well. So by getting comfortable with it beforehand, you're strengthening up the muscles appropriately. Then when you come out on the other end, it fast tracks how long you're going to have for your recovery.
So you talk about male issues with pelvic floor. What's female? I know it's a childbearing is the most common, but what other thing can affect the pelvic floor?
So it's actually our habits, which is so mind-blowing. Whenever I have a presentation that I give, there's a slide that I have, and it's just a list of habits for people to look at to see, okay, am I doing anything that's on this list? And I always love to see people's response when they're looking, and like, you can just see their jaw drop of, oh my gosh, I do these things. I do so many of these things. The big ones are the just in case peeing. I don't know if you've ever heard of it. So just in case peeing is that you're about to go to the grocery store. So just in case, I'm going to go ahead and stop in the bathroom to empty my bladder.
I think I do that all the time.
All of us do. I know.
I need to go somewhere. I always can pee.
Right? There's always an emptying. And the reason for that is the bladder always has something residual left in there because it's a hollow muscle. It needs that. So it's always getting stuff dumped into it.
But it's not a good idea.
Right. So the reason why is because the bladder can fill to a certain rate. Like there is a normal rate that it can. If we keep telling our body, no, you can't fill this rate, and you're actually filling half of that, now your bladder always thinks, oh, I have to empty because I can't fill anything past this.
It's like a stomach.
Yeah.
You stretch your stomach with food, and it's stretching more and more every time you put more.
Yeah.
If you stop eating, stomachs shrink, and you eat less.
Yep.
So same thing. It's like muscle memory.
Muscle memory, yep. So that's one of the big habits. And then another really big habit that actually goes both ways. It happens more for females than it does for males. But it's doming, which if you look down and you're doing a core contraction and you see that bubble that's happening in the center or your abdomen, you're pushing out. Most of us love to push because it creates pressure, which feels like we're doing something. But that pressure actually creates laxity in that center line of our abdomen, leading to DRA.
What's
Also,
the DRA?
The diastasis recti abdominis.
Yes.
Yep.
Okay.
And then The other thing that will happen is it starts to push down on the pelvic organs as well. And then those can start to move downwards, and that's how we start to get pelvic organ prolapse. So a lot of times people will get these mesh surgeries or these things to help lift up the organs, but they never address the root of why it was dropping down. So they're getting revisions done and things aren't really changing. They have to keep kind of going back. And at a certain point, then the surgeon says, I'm done correcting this. I can't do any more for this. But if you had just worked on the mechanics, then things would do much better. So you're seeing it a lot for females during different stages. You're not normally seeing it until they're a little bit older and we're seeing their estrogen change. So perimenopause, menopause. But that doesn't mean that's the only time I've seen it. I had a female, she was not in perimenopause, she was getting close. She had never had any kids and she was having a prolapse, and it was all due to mechanical things that she was creating. She had a little bit more complexity. She also had a fibroid as well, so that was just kind of disrupting the tissue too. But that's the reason why it's so important to look at all the symptoms, all the things that you're experiencing, and then getting all the right testing done as well too.
And is it overflowing blood too? Is it not good when you're waiting for a long time to go to the bathroom? So it's become a stretch. Is that the problem too?
Yeah, so it's that balance. Ideally, the bladder can fill and then empty every about 3 to 4 hours. Asterisk next to that, because everybody's bladder anatomy is slightly different. Some of us have a more narrow neck, meaning it can't fill the same exact way as someone else's would. So I say like 3 to 4 hours, but I would never tell someone hold your urine for 3 to 4 hours until we really look at a bladder diary, figure out what's going on, and then we want to make sure that we empty. But we don't want to be emptying too soon before that either, because then we're confusing it. So there is that middle ground, because if we hold too long, then we get urinary tract infections. If we empty, then we're creating urgency. So it's kind of a back and forth. We have to figure out what's the right balance for you, and bladder diaries are the sweet spot of being able to figure those things out.
And speaking about uterine prolapse, and you see probably a lot of clients with that, do you work with OBGYNs who supposed to take care of this problem? Do you have doctors who refer to you? Do they even know about PT that can help or prevent it?
Yeah, so I think a lot of times the OBGYNs are normally sending off to urogyns. That's kind of like a normal route for some people that they've been going. And depends on the urogyne. Sometimes they will send people off to pelvic floor PT, which they recognize, hey, this is going to help my client in the long run. That makes sure that everything's going to sit the way it needs to after surgery, because once we've gotten to a certain degree of a prolapse, there's a different grading. So grade 1, grade 2, lower end, things are kind of moving down, but not really far down. Once we get to 3, 4, it's a little bit further down, and it's a lot harder for things to go back up to where it should. And that's where we'll do pessary rings. So they have to get fitted for those types of things. That's where the urogyne will come in sometimes. Or they'll get the surgery where they get the mesh ends of things. They recognize if they do pelvic floor PT beforehand, it helps their outcome. They're not doing surgeries over and over again. I'm actually getting more referrals because men who are getting their prostate removed, they're coming back to their doctor complaining that they're still having urination issues. I had a male come in 2 years after his surgery, which is just so sad, because he just dealt with it for 2 years, which you shouldn't have to deal with those symptoms. When people say, oh, that's normal to aging, or oh, that's normal after having a child, that's not normal to not be able to control things. We really want to make sure that you're getting to figure out why it's happening, and then start to address those components to it.
So who else can refer clients to you? Who would you like to work with as a practitioner?
I actually really love working with personal trainers. It's like not what people are thinking.
For prevention, probably, right?
Yeah, and so it's mainly because my personal trainers get to watch them move all the time. They get to see all their movement patterns. And it's probably my favorite working relationship. Chiropractors are another really great one to work with, because they're working with the lower back. They're recognizing, hey, my client's telling me they've had a lot of kids, and I get really great referrals from chiropractors.
And mostly because they have a pain somewhere,
Correct.
So pain related.
Yeah. So the reason why I love to work with personal trainers is because they're movers and they want their client to get back into movement. And I love my people to get back into movement and integrate their pelvic floor into their movement patterns. So that's the reason why I love working with personal trainers, because I will always go back and forth with them. Hey, here's what I found today during my session. can you take note when they're doing these types of exercises, what compensations you're seeing when they get fatigued? Because I'm seeing them when they're fresh and they're not doing a lot. Then we start to make tweaks to their program of, okay, here's what we need to do on their warm-up program. Let's get those hips open beforehand. It's probably my favorite working relationship. That's why I love getting referrals from them. So I would say personal trainers are kind of one of my favorite ones because their clients want to get stronger. The pelvic floor is the base of your core. So if you're able to activate and use your pelvic floor, you're going to get stronger and you're going to feel stronger. And so then the personal trainer is excited because now they're lifting heavier weights and they're getting stronger and they're feeling better.
And get to their goals.
Yeah, and they're getting their goals and sometimes surpassing them, which is the best. And so I always love when I can work in a team. That's my favorite. Whereas normally when I'm working with most other doctors, they're just sending someone and then I'm just sending notes over. I don't really get much correspondence back and forth.
And hoping that they read your notes.
Yeah, that's the big part. For sure.
Professional athletes or even not professional athletes who don't work with personal trainer, what do they need to know about exercising correctly or not correctly? Or what exercises can affect pelvic floor?
So a lot of times I have people who come in and they like to do home workouts instead of going to a personal trainer. And sometimes they're following apps. Those are the times that I'll have them come in and I say, hey, can we look at the core part of what you're doing? Because the core is what all of our limbs are coming off of. So if they're doing something upper body and their core is weak, that's going to impact how their movement pattern is, and it's going to impact the pelvic floor as well. So if they're doing that doming that we talked about, so the abdomen kind of pushing out, they're pushing down on the pelvic floor, they're tightening the pelvic floor, they're disrupting some of those organs. That's why I always look at core programs for people, because if you can get that down, this is how to activate my core so that when my arm comes up overhead, then I can get everything nice and stable and I don't have to worry about, okay, do these pieces. It just kind of instinctively happens. The body doesn't even have to think about it. And then every once in a while I have people who say, I don't even want to work out. I don't want to do those things. I just want to do my everyday life. I will still look at their core, because the same exact thing as when I was saying people who are punching and putting weight up overhead, that's the same mechanism as when you put your plates up into your pantry. When you're grabbing something out of the refrigerator, it's all functional movement patterns that we need to be good with and strong with. And the core is the biggest component to it. I would say core exercises are the most important, but core exercises are the ones that people tend to do incorrectly that can impact the pelvic floor as well.
So you show your clients how to engage pelvic floor or how to do properly all those core exercises or movements?
Yeah, so the way I normally break it down is just like in any other thing that we're doing, you want to isolate the muscles so that you even know what you're doing. Because if I say to someone, let's go ahead and contract the pelvic floor, they could just be squeezing their butt cheeks together and thinking that they're grabbing their pelvic floor, but they're only using a accessory muscle. That's not a true pelvic floor muscle. Or squeezing their knees together. That's not pelvic floor, that's accessory. Those muscles on the inside of our thigh tie up onto the rim right where those front pelvic floor muscles are, so it's all compensation. Once I can start to find their compensations, teach them, hey, notice when you're doing these things, let's start to pull ourselves out of that. This is how we actually activate the pelvic floor. They're aware of it, but then you got to integrate it. And that's where I teach them certain exercises of, okay, here's how to activate the breathing pattern, getting all the muscles to activate together, and then incorporating movement as they're starting to get stronger, but then tying it all foot to core, which is so, so important.
When people come to you, you do assessment, and that's how you find out what's dysfunctional of pelvic floor and what they need to do. So tell us what's included in your assessment and how do you assess people?
So my assessment is really more complex because we're trying to look at you as a whole. So you might come in for hip stuff, you might come in for low back stuff, you might be coming in for pelvic floor stuff saying you're leaking or having issues with bowel movements or pain with certain things. Then I'm not just going to be looking at pelvic floor, I'm making sure I'm looking at the whole picture. So I'm looking at sleep, I'm looking at diet, because all of that's going to impact the tissue, and that's all in my intake. So my intake is about 17 pages long. I read the whole thing, and it's because I want to know the whole picture of what you're experiencing. And then after I read through that, then the true assessment component is me having the person walk, because I want to see what are the feet doing with the knee, with the hip, with the back, with the arms, with the trunk, with the neck.
And posture.
Yes, and their posture. I'm always secretly looking at that, because if we are sitting and we're sacral sitting or posterior tilting or just sitting back on our butt, that means the back of our pelvic floor is always getting input. That's always in the back of my mind to know, okay, they're probably a little more active in that area. Or do they tend to sit really far upright? They're an anterior tilter. The front of their pelvic floor is always getting input. Is it a little bit tighter? So that's just letting me find their trends, because I can give you all the right exercises. But if you're day to day, you're doing things that are going to impact that and undo it, you're going to feel like you're never making any changes. So that's why we got to look at the whole picture.
And that's habitual.
Yeah.
You need to change your habits.
You don't even think about it. Yeah, you're just normally doing it. So I normally tell my patients every time, I'm like, hey, this week, this is what we're going to focus on. Just start to notice when we're doing these things. And I don't ask them to change it. I just ask them to notice it, because just bringing awareness to it, then they start to say, wow, I really do that a lot. And then they can start to integrate the exercises into that. So after I've looked at some posture things, how they walk, then I'll look at spinal movement. So how is it when they bend down, touch their toes, come backwards, rotate. And then I'll look at the feet, because the feet fascially are tied up to the pelvic floor. So if there's tension or poor stability there, it's going to impact up the chain. And then when we look at the pelvic floor, I do that very, very different. So traditional pelvic floor PT is something I can do, but the area that I work in, most of my patients are coming because they need a different type of experience. They've already been to pelvic floor PT. They've already been to 15 other doctors. Me poking around in the space isn't going to make any change. Them connecting to their pelvic floor is where you're truly going to start to make an impact. Remember when I said earlier, most people don't connect to their pelvic floor. They have no idea what's going on. If I start doing an internal exam, so I have a glove, I'm poking around and I'm saying, hey, this is tight, this is this is that. They say, okay, thank you, note taken, let's move on. If I start to teach them through breath work, them sitting on a towel for their biofeedback ends of things, oh, hey, this is what tightness feels like. This is what it feels like when it's relaxed, when we're doing breath work. They can connect to their pelvic floor. They can start to feel those things. They know what it feels like when it's activated and when it's relaxed. And that's how I do my assessment for the pelvic floor.
When you said internally, what exactly do you do internally?
So we can do it two different ways. So we can do a vaginal assessment for females. You can also do rectal for females, but also that would be for your males. And you're looking at a couple different things. First off, you're just looking at the tissue. So you're making sure, is it healthy? Is it hydrated appropriately? Is it getting good blood flow? Are there any abnormalities in the tissue? And then before you even go in, you're poking that tissue to see, is there pain? Is there any discomfort? Because if someone's already in that hyper alert, you just going right in, oh, it's going to hyper alert them even more.
And tightness, right?
Yeah.
Tightness or loose tissue.
Yeah. After you've done that assessment, then you go internal. You're looking at the different layers. So you're just slowly inserting and you're going from side to side, trying to see, is there any pain or discomfort? And then once you're fully in, you're looking to see, what does the activation feel like? Are they able to pull your finger up and be able to get that good contraction? Or are they just clasping around? Or are you just feeling the back move? Yeah, you're trying to get a good assessment of what's happening in the tissue. When
So you ask the client to do different things so you can see the muscle reaction.
Yeah, so you're asking them to breathe to see if you can even get the pelvic floor to move with breath, because when they're doing true diaphragmatic breath, pelvic floor will mirror that. So as you're inhaling, diaphragm comes down, pelvic floor will come down. And then when they are going through like a cough, what's happening? Do you feel pressure coming down, or do you feel the finger like kind of getting pulled back up? When they're contracting, is it coming back up? When they're having a bowel movement, what are you feeling? All those pieces so that you can actually figure out what's happening with the pelvic floor during all those different aspects of life.
What dysfunction do you see the most when you assess your clients?
Urinary leaking. That's the biggest one.
Female and male?
Mainly females, but for my males, it's normally after the prostate, so that one makes sense for them. So it's simple things of, okay, I went and I was chasing after my kids, and then, I started to leak a little bit. Sneezing. I've had so many of my moms not be able to jump on a trampoline, which is so sad.
Yeah.
It's like so sad. We did a membership one time with my son, and I was running across, jumping everywhere, and you could just see all the moms sitting on the sideline like, I just want to be able to do that. And I was like, oh, just get your pelvic floor assessed.
Just come over, I'll fix it for you.
Yeah. So that's definitely one of the biggest ones. And then tied into that sometimes is also urinary urgency. The urgency comes from normally our habits. So that's why habits are such an important thing for us to look at.
Well, speaking about urine incontinence, how women can prevent it besides going to PT? Can they do something at home or even in the long run, premenopausal, or even before having kids? How you can prevent it for the future?
For the future. So I have definitely seen people who have had incontinence and not even had kids, which everybody's just always, oh, you had kids, and that's the saddest part. I don't know how many times where I've worked with moms, and on their intake, it will tell me that they have urinary incontinence. That's not what they came in for. And I say to them, well, how long have you had this? And I'm like, oh, since I had my kids, but that's normal. And I'm like, what? That is not normal. You shouldn't have to deal with that at all. So I would say one of the biggest things that's really, really important for people to recognize is if they are butt gripping. So most of us females, we tend to like really hold tone somewhere. Butt gripping is like one of the biggest ones. And then the other big one is abdominal tension. So we never really take a true diaphragmatic breath. We always hold all this extra space because somewhere in our lifetime, it's usually when we were younger, we were told to suck in our stomach, cross our legs, and sit up straight and get our chest out. And that actually puts us in a position where we're overextended. You can't really properly stabilize through your core, so it becomes really dysfunctional for your pelvic floor. So fixing posture, those types of things are really important too. And then just starting to work on decreasing tension and then activating the pelvic floor gentle, not always doing a hard Kegel all the time. So sometimes Kegels actually are the worst thing for us.
So what's most misconception people have about pelvic floor or pelvic floor dysfunction?
I would have to say that the thing that I've always heard is, oh, that's only for women, which always is so frustrating. And, oh, you've only had to experience it if you've had kids. That's definitely so false. There's so many people, different walks of life, different things that they're experiencing. I mean, there's pelvic floor PTs for kids. Sometimes people have been experiencing issues since their childhood. A lot of times we have intolerance to things. We're not actually truly allergic to foods, so we have an intolerance to it, meaning our body can't process it appropriately, but we're not going into like a full rash, but we'll have digestive issues or we'll have bladder issues.
Inflammation in the body.
Correct, yep. And nobody's thinking about the whole bladder health and bowel health ends of things. That's going to impact the pelvic floor. So these poor kids who have really bad constipation or really loose stool because they have really bad diarrhea from it, they need pelvic floor PT. And kids who are taking in maybe apple juice, and apple is actually an irritant for the bladder for some people. We don't think about that. And then that more irritation creates inflammation. And then the longer they keep dealing with that, they have to wait until they're older, and then they start to get pelvic floor PT.
I think that related to apple is probably salicylic acid.
Yes.
And the reaction, that's what created. And also a lot of kids in school, they're afraid to go to the public bathroom and the hold until they get home. And the more we hold it, the more inflammation. And is it related to one of the causes of the pelvic floor, or pelvic floor cause constipation? So which one?
Right?
Chicken or the egg?
That's such a good question. And I wish I could say we definitively know, but we don't. It's very, very hard to say. I love asking this question when I'm in a group of people because everyone gets so deer in headlights. Oh my gosh, did she just ask that? I always ask people, I'm like, raise of hands, how many people were taught how to poop correctly? And no one raises their hand. And then I always say, my son can raise his hand because I made sure he felt very comfortable about how to poop. And I mean, that kid could go anywhere, to be honest, and he has no fear of going to the bathroom. I think we visited many bathrooms out in public, and he doesn't care to be able to have a bowel movement. He will, even at circle time, he'll raise his hand and be like, hey, after we're done circle time, can I go poop? He has no fear in even telling people that too. I think that Some of it is kind of society that we aren't able to talk about those components, but it's also because we were never taught how to do it. And then our kids are just being kind of subjected to the same exact thing.
Yeah, we are role model for them. We don't know
Right.
what to do with that, and we don't teach them to do that.
Yeah.
In school, sometimes they said, hold it, or you have a break for the
Yeah.
bathroom, and that's what happens,
it.
snowball.
And
Or
then-
sometimes stigma. They're afraid to go in public. And I see a lot of people, even women, when I go to the bathroom, women are afraid even to poop. But where else you fart? Where else you poop? Where else you smell if it's not in a bathroom?
Yeah.
But people are afraid to go in a public bathroom. So
Yeah.
they not release their
I know.
themselves.
I know. They hold so much tension. So when we go and we have a bowel movement, most of us are pushing to poop. When you push, you're actually tightening the pelvic floor, and now you're tightening and trying to shove something through. That's the reason why it's not great for the pelvic floor. It leads to prolapse. And then we're also pushing sometimes to go pee because we have this much time to go, and then that's creating a lot of issues too. So the habits of how we have a bowel movement definitely impact the tissue too.
We know that if there is a dysfunction of pelvic floor, probably neurological dysfunction happen, and it's affecting our digestion and affecting our going back to the brain, the vagus nerve and everything else, and also for the spine, all nerves that affecting our whole pelvis. So we're gonna have problem with bowel movement, with urination, even with uterus. So tell us more about poops. What's considered regular poop? What type of bowel movement or poop supposed to
Yeah.
be?
So the Bristol stool chart is the best one to use. I always have my patients look at that one.
And it's easier to find on Google.
On Google. Yeah. Ideally, you want a type 4. That's the best type because it's soft. You're not straining to have a bowel movement at all. And you ideally should be pooping at least once a day. That's the goal. And some people won't poop once a day, and they normally tend to be like more on the stiffer ends of stool. The reason why I always like to ask my patients what their stool is, because sometimes they'll say to me, oh, I'm a type 6, which is really loose. But every once in a while I get that type 2, type 1, which is like those rabbit ones where they're like hard balls, they're really, really formed. That's someone who's more constipated. The people unfortunately think that they have more diarrhea, so they keep treating diarrhea, but they're feeding into the constipation getting worse, and then that means the diarrhea is going to get worse. If you're constipated, it's going to be really, really dry, and everything can't move down easily. So what the body's going to do is it's going to backload everything above it with lots of water, and that's the reason why you have the diarrhea. The other reason why constipation is not great, exactly what you're talking about with the nerves, the bowels have something called the sampling reflex. This is something that I don't think most people really know about. The stool is not always sitting right there. It's not hanging out in that space. When you're constipated, it's hanging out in that space. You have a sphincter on the inside, your internal sphincter, not the one that you can see from the outside. That one is the one that's so important that says to you, hey, you need to go to the bathroom. This is hard stool, or this is loose stool, or hey, you have gas. When stool is sitting on that for a long period of time, it starts to stretch that out, and then we start to have a really hard time knowing, do I need to go to the bathroom? Is this gas? What is going on? Because we've now disrupted that communication. So another layer to the nerve component as well.
And if we cannot go to the bathroom where we have that sphincter reaction and we don't go to the bathroom, what's happening with sphincter? So it start responding to that. And that's when we lose the feeling of going to the bathroom.
Yep. So there's something really important called interoception. I think you've definitely heard of this component, but for anyone who hasn't, it's your body's communication to itself. So that's your understanding of, I'm hungry, I'm thirsty, I need to go to the bathroom. When we start to ignore those signals, you're starting to ignore a really important communication that your body has already ingrained in itself. Those are the people that become very disconnected, and those are the people that have a really hard time figuring out what they need because their body's been giving it to them, they've been ignoring it, and the body can't give it anymore.
I even relate it to food. So if you ignore your hungry symptoms and you stay for a long time, you're not hungry anymore.
Yep.
And sometimes it's even happened to me. I don't feel hunger, but I start having headache. Because this is another way body's telling you don't have enough nutrients in your brain, even though you don't have a hungry symptom. Same with the poop. So if you ignore that you want to go to the bathroom and you don't go, you create first constipation and you ignore the symptoms. So it's everything's become backing up.
Yeah.
So it's very important.
So important to listen to your body. But it doesn't mean that you run every single time.
Right.
It just means listen, just take in the information and then decide, did I just go to the bathroom? Do I really need to be going? Or, hey, I haven't gone in a little while. I actually do really need to go to the bathroom.
And I like that you take holistic approach to assessment and you take in consideration the nutrition and exercises and you assessing. And as we talk about it, it's very taboo and people feel uncomfortable talking about pelvic floor. So how do you work with clients when they come to you and opening them up to even do internal assessment?
The biggest thing is that you have to have confidence. So like as a practitioner, if I have any hesitancy at all, my patient's not going to want to do it. So I have to come in and I have to feel very comfortable with able to say, hey, you know what? Here's a really great option for you. I'm going to let you make the choice, because that's the other part that I always say to my patients. I know that I'm the professional. I know you're coming to me, but in the end, it's your choice and it's your decision of what you feel comfortable with. If you want to cover this today, we have all the tools right here, and here are your two options. We can either do an internal, this is how it would look, or we can do an external, this is how it would look. And if you tell me you're not ready for it, I will give you all the resources, tools, and information so you're informed, and then you can decide when it's going to be the right time for you. But recognize why we want to go down this path, how it's going to help kind of put everything back together, but you also be able to make the choice if it's the right time for you. Because I never want one of my patients to say, okay, if you're telling me I have to do it, I'm going to do it. As soon as I hear that from one of my patients, I say, you know what? We're going to switch gears. I promise we're still addressing the pelvic floor in some form or way. But I think right now, just getting you some resources, tools to understand what it is and why it's so important to you is more important than us just going through the steps of it. I want you to know and feel comfortable and confident with why this is the right thing for you.
And probably they can do internal assessment later on when they feel comfortable. Because if they're not comfortable, if they stress about doing that, you will see the tension of the muscles inside. So because they're holding and stress and everything else.
And then on top of that too, their nervous system is so hyper alert. Anything that I say to them, they're not going to be listening to it. They won't be able to absorb it. They won't be able to take it in. My favorite thing to do with my patients is educate them. If I can't educate them because their nervous system's up here and it's in a hyper alert, I am not able to give them all the right tools in that moment. So that's why I will tell my patients, because there's a couple of times where they're like, no, I promise you I want to do it. And I'm like, I'm not saying you can't do it. I'm just saying that right now is not the right time. So I'll normally share, I have a video of how I do this self-assessment. So they know what it would look like for us to just start with an external assessment. And then once we do that, sometimes I've had a couple of my patients say, I just can't connect to it. I'm really ready. And they mentally and physically are ready to be able to do that internal assessment. I never want someone getting pushed into doing it because the plan of care is dictating this and doctor needs this. No, you need to be able to advocate and say what's the right thing for you in that moment and be able to say, yep, I feel confident being able to do this now.
I call it informed consent.
Correct.
So when they're educated about something, they're more willing to do certain things. Another issue, as OBGYN, I saw a lot, it's pain in pelvic floor, pain during intercourse. And I didn't know back then, but a lot of things related to sexual abuse and a lot of things related to sex and stress in the pelvic floor. And as a result, it's become a pain somewhere in the pelvic area. How do you address that trauma, that trigger pain and create the issue in the pelvic floor?
So unfortunately, that is really common. And I always say to my women that it's really important to make sure that they have the right healthcare professionals in their team. So I'm not working alone on that. And one of the biggest ones is working through the emotional component. So if someone's not already done a little bit of like talk therapy.
And trauma therapy.
Because
it's not always talk therapy.
It's not, They need that extra layer of it. They need to find the right person though too. And that's what I always say to them. Don't just go through the motions of it. You're interviewing them. If it doesn't feel like the right fit, then don't force it. And then depending on where they are in their journey, sometimes I've also had them do somatic therapy as well to work through the emotional component, but then be able to do the movement and be able to release some of those pieces that go along with it. I normally in those instances won't do internal assessments on those patients, and it's because it's a full trigger. I am trying to be so respectful of that space for them, and I actually start to try to mimic body language as much as I can. So if they start to need space, then I give them even more space. So I'm always just trying to create a safe environment for them. They do the self-external pelvic floor. I space out their appointments a lot more. They are not consistent back-to-back type of things. We're just respecting their space and what they need. But then we're also recognizing what kind of tools might they need. So if they're having pain with intercourse because the muscles are so tight, that's normally the biggest component to it, is just getting the pelvic floor to relax, because now blood flow can happen in that space. Then we're starting to figure out, okay, what other things do they need? Sometimes I've had my patients need dilators. There's different sizes to them, and they're soft. They should never be painful or uncomfortable. That's why it's really important to do it with a professional. And you're slowly working through increasing the size to get closer to the anatomy that you need or want to get towards. And you're doing it in your control. It's never including anyone else until you are ready for that. And then I always encourage them, if they are with someone, a partner or whoever it ends up being, if they feel comfortable and ready for it, then I say, hey, when you feel ready and you understand what's going on, you can introduce your partner into it, and it can become something that helps initiate intercourse instead of it just being boom, everything goes and your tissues going back into that. The biggest thing I always say to them is advocate for yourself in the bedroom as well too. If it becomes painful, the tissue has the muscle memory to tighten up because it's painful. And when you're trying to work through it, if you keep letting it get tight, you're going to keep getting back into that habit where it gets tight. If you can be open and communicate to your partner and say, hey, pause for a moment, I need to take a couple breaths, then you can work through it. That's going to make a big difference for the tissue, and then also how they experience on their end as well too. Because a lot of times they're just like, okay, just get it done with, and they're not able to experience any pleasure out of it. And that's a main function for the pelvic floor as well, is to be able to get that full pleasure, body, nervous system, everything feels relaxed after that as well.
It's a great idea when person already working with other practitioners and they refer it to you.
Yeah.
But what if it's happen opposite? So they come with pelvic floor issue, they don't even relate it to their past trauma, and you start working with them. How do you deal with that?
So I haven't had it happen in my pelvic floor realm of things because our paperwork has an aspect on there asking about trauma, but we've worked with so many people. Even if someone hasn't given that to me, we can see the pattern. So we're just always constantly trying to be ahead of it so
And
it doesn't
aware of
happen.
it.
But I have had those types of things happen to me with my patients when I'm doing craniosacral work. Like everything's relaxing. You're not doing anything aggressive to the tissue, but you're opening space for the nervous system to feel comfortable. And in those instances, I recognize it's not in my scope of practice at all to guide them through anything. All I do is I say, hey, I'm holding space. I'm here for you. And I let them have their moment. I hold the space for them. And then I refer them off to someone. And we just make sure that it's the right fit for them. And we have the conversation of what they're looking for. What are some of the things that they are kind of trying to look for someone and talk about. And we just are a constant support system for them through that entire process. We're always hoping they have someone set up beforehand, but it has happened in the past where they don't have someone. We've opened that space for them, and now we want to make sure that they're getting guided through it appropriately.
Interesting, you mentioned craniosacral therapy. So it's another modality that you use for your clients.
Correct.
Anything else that you use for your clients additional to pelvic floor assessment and craniosacral?
Everybody always thinks manual work has really got to be an intense type of thing. Like we're doing a manual release in the pelvic floor. We're going in and we're poking muscles and doing those things. But the reason why I love craniosacral is because it's gentle, soft touch, but it's impacting all of the tissue. Like it's getting everything from head to toe. and integrating it together. We also do visceral mobilization therapy. So you're going to the abdomen and you're working through the fascial tension of the organs as well with that one. Always love to kind of do a little bit of work together, but recognize where the system is. Not a lot of overload of those things and giving space out in between. And then I also do a lot of work with TMJ. A lot of the tension that we have here in the jaw mirrors a lot of the tension that we have in the pelvic floor and low back and hips. We want to make sure that we're looking at both pieces of it. And so I'll do TMJ work with people, like releases, mobilizations in the jaw, cervical spine mobilizations, working through the spine, trying to help loosen it up a little bit too.
And also craniosacral is related to parasympathetic nervous system. So if you balance it, then your body can heal. Speaking about other part of the body, and you start mentioning the jaw related to pelvis, any other organ can be a problem in other organs or part of the body related to pelvic floor, or opposite. Some trauma or disbalance of other organ or parts can be a cause of the pelvic floor. How is the connection with different parts?
And that's why I always work with Ariane too. Ariane's the functional medicine practitioner that's at the Movement Paradigm with us, because the gut is a big component. Like we've been talking about constipation and irritants within the bladder, but sometimes our diets, like people that we tend to see who are more vegetarian type of diet, that's totally fine for some people, but sometimes those high starchy types of foods actually creates like a gut disruption. And a couple of our patients who have been vegetarian, they had vulvodynia. So they had that pain within the vaginal tissue right on the outside, couldn't sit, couldn't do certain things. Pelvic floor PT was not the only component that they needed. They really needed to look at the gut to address getting some of that balance back, help with the digestive enzymes. We couldn't change diet because they didn't want to eat a lot of the animal proteins. So we just need to respect that, figure out those pieces, and then making sure that we're not contributing more to that dysfunction as well.
What would be the cause of vulvodynia from the vegetarian?
So it's the high starchy. I remember I was working with this patient. She had a lot of foot stuff that was going on. That's why she originally came to me. And then as we started to uncover, we started to realize, oh, she had vulvodynia. And then I said to her, I was like, I feel like there's more to this picture. And so we sent her off to Ariane, who had done the stool test. And we had seen she had small intestinal bacterial overgrowth. And it was all being fed from the diet that she had. So we were just trying to get her balanced a little bit more, but making sure she was getting the nutrients that she needed as well. And then just respecting too the way she wanted to get her protein. The way all that's being broken down as it's coming through can irritate the tissue. And so that was irritating the vaginal tissue. Now another layer, that same exact patient had also experienced some sexual trauma within their past.
So combination of different factors create the problem.
Yeah, it's never one thing. There's always root causes.
What's the other misconception can be about the pelvic floor, and how you dismantle those?
My favorite way to do it is I go to workshops and I start to educate people, and I start to just tell them things. Mainly the habits are like the biggest things, because we don't even realize, everybody always thinks, oh, I have to be doing something that's creating my pelvic floor to be that way. Oh, if I stop jump roping, my pelvic floor is going to be so much better. Oh, if I stop doing these types of workouts, my pelvic floor is going to be better. But the habits, I think, are probably the biggest things, and starting to educate people on those components, and then just getting people aware of what signs and symptoms are that are some pelvic floor related things. Because,
for example, we didn't talk about some.
Yeah, we didn't talk about those. So we talked about leaking, we talked about constipation, painful intercourse. One of the big ones is if people feel like they're having hesitancy. So if they're going to the bathroom and they have this urgency, so they feel like they need to get to the bathroom. Then they get to the bathroom and they're sitting on the toilet and they're like, why can't I pee? And then their stream starts. That lets us know the pelvic floor is really tight. But which layer? Which layer is tight, and why is that happening? Having leaking, so it happens to females more so when there's a prolapse. That's usually the biggest thing that it happens with, because the urethra, the bladder is not on tension anymore, but pulling that urethra kind of down. And so you don't have that good chute. You kind of have a little loop that's in there, and so we can get that little pocket. So when they stand up, now they have a little bit of dribble that's happening. Happens to females a little bit less than it does to our males, just because of how their urethra is. So males tend to experience more of that dribble afterwards. Sometimes they sit down to pee and then they dribble a little bit after. That's pelvic floor related. And then one of the biggest ones that I always talk to people about is peeing more than once at nighttime.
A lot of people wake up at night to go pee.
Correct.
So is it a pelvic floor?
It is, but it's also habits too.
And it starts happening more when we age.
Correct.
Because of the lacks of the muscles, like everywhere in the body, everything gets slack.
So once we hit perimenopause or menopause too, it's actually very, very common for us to get up in the middle of the night to go pee at least once. And it's because estrogen has decreased within the tissue, so there's more laxity. But then our antidiuretic hormone has also been impacted as we age as well. Antidiuretic hormone is really, really important to us being able to hold on to urine. If it's not functioning, it's not as prevalent within the tissue, then that's the reason why we're peeing. The reason why we shouldn't be seeing these things when we're younger is because the tissue is nice and healthy. We do have that antidiuretic hormone. That's more habit. Those are the people who drink water a lot, drink water really close to bedtime, drinking a bladder irritant or eating something close to bedtime that irritates it, and or they're also getting up in the middle of the night, going pee, and then drinking more water, so then they're just feeding into it. The reason why it's so important for us to not get up multiple times in the middle of the night is because the sleep cycle is really, really important. So if we are falling asleep, we're getting into our deep sleep, we're coming in and out, and we're just staying within those later cycles. If you get up, you pull yourself out of that deeper sleep, out of those later cycles, and now you have to go back through the cycles again. So you're not getting into a deeper sleep for long periods throughout the night. You're kind of disrupting it. That's why I tell my women all the time, it's so important to start to figure out why you're getting up, and then we're going to go ahead and pause those types of activities.
We spoke about different part of the body related to pelvic floor, and I know you specialize in feet. So how feet can be related to pelvic floor?
We have to recognize our communication with our environment, hands and feet. Like that's our biggest piece of information. Lots of nerve endings here. So if our feet, we're always wearing really cushioned shoes and we're always wearing a shoe, we're decreasing the input that we have on the bottom of our foot. Our foot then needs to work harder to get information. At a certain point, the longer we do that, our foot kind of gives up on it, and now everything up the chain is working a lot harder, taking a lot more impact. So that's one of the layers to it. But the other layer to it is fascially, our big toe, there's one muscle that goes to our big toe called our flexor hallucis longus. It is fascially tied from the foot all the way up into the pelvic floor. So if our walking pattern, we're not very efficient coming off of our big toe and not loading that appropriately, it's going to impact how the rest of our tissue loads, and it's going to impact the pelvic floor. Our feet are also where we get our information to stabilize from. If we don't have good stability at our feet, now the pelvic floor has to work a lot harder. So I always love to give this example. I had a woman, she had a baby, and her baby was breech. She worked with a doctor to do a breech birth, which was part of her plan, and that's all he specialized in. I know it sounds crazy, but it meant that the tissue was a little bit more disrupted. She had a vaginal birth with that baby. 4 days later, she was holding her baby and she decided she wanted to move a piece of furniture. She moved the piece of furniture with her leg, but all that fascia up the chain got really irritated and it went right to the pelvic floor. She had a muscle spasm within her vaginal tissue. She went to her doula, who said, "Oh my gosh, I can't treat this. Like, you just had a baby 4 days ago. We can't touch this tissue. Go to your pelvic floor PT." And so she came in and all I was saying was, "Oh my gosh, how can I treat your pelvic floor? This is crazy. I can't do anything for it." And then I had this moment where I was like, I don't need to treat the pelvic floor. I can look down the chain. I can look at the fascia. So we did a foot release and we did a calf release. And that fascial tension up in her vaginal tissue decreased. Didn't disappear, but it got much better. So that's the reason why it's so important to understand and integrate the pelvic floor into movement, but more importantly into the foot, because it's all fascially connected.
What shoes would you recommend to wear?
I can never blanket statement that these are the best shoes. And the reason for that is because everybody has a specific foot type. So your shoe needs to be based on your foot type.
So go to orthopedic and they can create your orthopedic shoes?
Close. You can actually just do an assessment with me, and then what I normally tell my patients, you have a flexible foot or you have a rigid foot. If you have a flexible foot, you can get a shoe that has some movement to it. Like you want a little bit of movement. Now it also depends on what you're doing. So if you're a trail walker, then those barefoot shoes that you're talking about, totally fine for certain foot types. But if you are going to be running on concrete, I don't want you in those barefoot shoes. There's no cushion to it, meaning your foot is taking so much more impact. It's because vibration of
stress
the floor.
On the feet.
So if you're on hardwood floor, your foot is going to absorb some of it, but so is a hardwood floor. Concrete does not. It sends every bit of that vibration back up into your body. So a lot of stress up into not only the foot, but all the way up towards the pelvic floor. So it's kind of like sitting like a hammock front and back and side to side. That's where it's all going to get absorbed into. So you want to take into account the foot type for the person. So are they flexible or are they a rigid foot type? And then what is the purpose of their shoe? So are they going to be running on certain surfaces? Are they going to be walking on certain surfaces? But something across the board that I always tell my patients, you want a wide toe box, but not a wide shoe. That's the reason why high heels are not great, is because it's putting you up on the ball of your foot, and then it's really, really narrow. Like some of them are even pointed. So now you're up on the ball of your foot and you're in this really tight space. You're losing your main stability. When you're in a nice wide toe box, your toe should be able to splay out to give you a better stable position to push off of. Most of us don't think about it, but the sneakers that we're wearing high heels. And people are like, what are you talking about? And it's because if you look at where your heel sits to where your toe sits, most people have a higher heel to toe drop. So most of our running shoes, if you kind of look at every single running shoe that we have, most of them have a difference from their heel to the toe, putting people up on the ball of their foot in a narrow toe box.
And you cannot find flat sneakers, correct?
Correct. So there are companies who make them, and I always
recommend... Even runner shoes are not for running?
Nope. Yeah. So there's one brand, I won't call them out. There's one brand, they love their cushion. And everybody's like, it's like walking on a cloud. And
I just saw Balenciaga.
Yeah.
With all fancy sneakers for running. With like this
really
platform.
Yeah, it's like 3, 4, 5 inches for some of them.
Looks fancy.
It does. But you have to think about it. When we hit our 4th decade, that's the peak of the sensory neural input that we're going to have on the bottom of our foot, which is crazy to think about. And then as we age, it starts to decrease. And not only do we have that decrease in neural input from the bottom of our foot, now we have all this cushioning on top of it, so our poor foot has no information. So that's the reason why we don't want to have all that cushion at all, because it's just so bad for the foot as well as everything up the chain as well.
How about flip-flops?
Yeah, so I'm a sucker for my flip-flops. I love being barefoot as much as I can. Flip-flops are actually not too bad because it does give you the width, but you don't want the flip-flops where you feel like you're always grabbing and holding on. You want something that has more of a strap to hold your foot in place so you have a little bit more stability.
Like flat sandals, that's the best for summer.
Yep. Yeah.
Or if you can go without shoes, even better.
Yeah.
Talking about arch, so a lot of things have like memory foam or specific arch. Is it important?
Depends on the foot. There are certain shoes that I will recommend for different pathologies of the foot. So if someone has something going on with their big toe, I will put them in a 4-foot rocker shoe, because the toe is where we get our roll from to be able to propel ourselves forward. If the toe has arthritis or it's jamming too early, that I need the shoe to do that. But someone who doesn't have toe issues, I won't put them in that type of shoe. If you have a really good arch, but it keeps collapsing, you just need to work on exercises. So I might put someone in a temporary orthotic where they're getting the support so that if they wanted to go on their hikes and they wanted to do things, they could be supported where they needed to. But if you always give your foot that, then it relies on it. And so your foot says, oh, I'm always being supported. I don't need to stabilize and I can just use this. It actually leads to weakness down the road. So that's the reason why I don't do it. Now, certain things, every once in a while, I will put my patients in those types of shoes so they have that support, but I will also give them exercises to work on strengthening that appropriately.
And I think also would be good when you alternate different shoes. So it's not always memory created in a muscle, always have the same type. So if you alternate different shoes, that would be better for the feet.
Yeah, and the shoes only have so many miles in them too. So we want
Don't wear old shoes for.
I think my biggest pet peeve is when my patients say, "Oh yeah, my running sneakers got really bad, so I just use them to cut the grass," and I just cringe so bad. I'm like, if they were bad for you to use in that activity, we shouldn't be using for other activities. Just toss them, just get rid of them. I know we don't want to wear nice sneakers for cutting the grass, but your poor feet will thank you later for that one.
We're coming to the end, but I want to ask personal question. Both of my baby were breech, and I had to have planned C-section. But what I know now, I can relate why my babies were breech. Because when I was teenager, I fall on my butt, and I broke my coccyx. What did it do for my floor, pelvic floor? I don't know. But because of that, probably baby couldn't lie properly. So that was the best way for them to find a space in my pelvis to be a breech. And when you have first baby breech, they don't even look how lie second baby, they just do planned C-section. And of course now I have a cut in my muscles, right? So what can I do now after like 15 years of having babies? To help my pelvic floor or help my abdominal muscles.
So you're definitely right. That definitely did affect the pelvic floor. So remember when we were kind of looking at the pelvis, you can see if this tailbone is just a tailbone. Everybody's tailbone is a little different. Some people have shorter tailbones. Some people have like longer tailbones. Everybody's is different. This is just normally kind of how they look. The tailbone is normally kind of curved a little bit in. If we fall on our tailbone, it's going to curve more inwards. And it's
or even going in.
And some of my patients have theirs where they're kind of sticking out a little bit. Everybody's a little bit different. But if anything is coming into that space more, baby is not really going to feel like it wants to drop down into that space. It's already tight as it is. It's probably a contributing factor to it for sure. When people have falls on their pelvis, whether it was on their sit bone or on their tailbone, you definitely want to see a pelvic floor PT.
So could you help right away after the trauma? Because that trigger also my sciatic nerve, chronic sciatica.
Yeah, so remember when we talked earlier about the piriformis being one of the wall muscles, when the piriformis tightens up, because the pelvic floor is tightened up, it's going to compress on that sciatic nerve, so you're going to get those discomforts. So unfortunately, it's never just like, oh, hey, do this one exercise and poof, everything feels so much better. It takes a little bit of time because really intense trauma happened into that space. So that's a lot of impact. But at least you'd have the tools to start to kind of work on, does the tailbone need mobilization? How could you do those types of things at home? How do you release the muscles? How do you bring the balance back into the tissue? So right after injury is definitely the best time to do it. Many years after, structurally, it's kind of become how it is for you. It doesn't mean you're stuck with it, but it just means you're going to have a little bit more tension, so you have to work through those things.
And yoga helped me with sciatica. So after trauma, for many, many years, I had a chronic sciatica. But when I started doing yoga on regular basis, it released, even during pregnancy, I didn't have sciatica because that's what usually pregnancy triggers sciatica. But the physical flaw kind of after trauma still existed and I never fixed it. And speaking about C-section, so any other abdominal surgery, how that affect pelvic floor?
So I deal a lot with moms who have had non-planned C-sections. Most of the people that I work with, their plan is to not have a C-section.
Or even planned surgery, it's still the cut in the abdomen.
Yeah. So one of the biggest things that we talk about is time frame. So the tissue within the first 6 weeks, you kind of just want to let the tissue heal. You don't want to be disrupting the tissue much. But then after those 6 weeks, you can start to kind of look at the tissue and help the tissue move. It's always interesting. The scar for an appendix surgery is so sensitive for people. I don't know why. They always feel like it's one of those things where they feel grossed out when they even try to think about touching it. So I do scar desensitization with them. So you take a towel, you wrap it around your finger, and you're just being gentle. And you're just going on the scar, just starting to get it to recognize it's okay, it's safe to touch this space. But if they're getting really, really sick while doing it, because I've had a couple of my patients do that, I recommend them going to therapy to start to work through why is it such a hard connection for the body to make? Why does it feel so nauseous? I'll do that for my moms as well, scar desensitization, and then we work on scar mobility. So scars are really important. We need them. Like if we've disrupted the tissue, we need that scar to form. The issue lies is when the scar is not being put in check every once in a while and it just starts ramping up. So scars are really helping create structural integrity back into the tissue with those collagen fibers, but they don't lay down very nicely. So when you're working on the scar, you're never going to break it up. I always tell people, you're never going to break up scar tissue unless you're going in with a scalpel and you're breaking it up. It takes 2,000 pounds per square inch to break up scar tissue. So we're not touching it. There's no way we're going to touch it. I always tell my patients, all you're trying to do is just teach the body, hey, the tissue can move in this direction. And the reason why we want to do gentle scar work, you're using your middle finger and your ring finger, you're going in circles clockwise, gentle, counterclockwise, and just going on, above and below the scar for however much time you feel comfortable. It's nothing forceful, you have to do it for this long. And then you're just doing that to start to say, okay, I can move in this direction. The reason for that is, remember we were talking about all those fascial connections, how all the tissue is impacted. Your transverse abdominis, which is your deep muscle that sits within the core, is actually fascially tied to the front of your pelvic floor. So that tissue gets disrupted when we have a C-section. If there is any scarring that's happening with that tissue, it's going to impact how the front pelvic floor functions for you. But it's also going to impact your breathing pattern as well, because remember, it's front of the abdomen. So I always tell my patients, if you're kind of like, well, I don't really understand the connection of fascial and how it impacts it because it's not even the same area. So my favorite analogy to use is, remember when we all used to wear stockings? And we wore the nude stockings? And the funny part was, we all knew we were wearing nude stockings, but nobody wanted to know that you were wearing nude stockings. So they had to be like the secret ones that like you couldn't really tell. So we're running out the door, we throw our stockings on, and it gets that dreaded rip in it. And we're like, oh, I don't have time. I'm not throwing these out. So we threw the clear nail polish on, right? Because we got to save these.
I still do.
We still do it, right? Yeah. We can't throw them out. They're expensive. So think of that clear nail polish as your scar tissue. So now in the front, you can see those stockings moving, whereas before you didn't see it moving. So that's the reason why we want to start to help the tissue move efficiently, because it's going to impact everything, how it all moves, not even just in the core, how the hips function, how the knee is functioning, how the neck is, all those pieces to it.
Can you restore that?
Yeah,
Okay.
So you do that through a lot of different things. Scar work is one piece to it. Doing myofascial massages with a true myofascial person, because a lot of people say they do myofascial, but they're just doing not true myofascial stuff. Craniosacral does help with that as well, because you're getting down to the bony component. And then also just working on movement, getting the body to go opposite patterns of what it's used to going into. After a C-section, flexion, coming down into that in position feels so much more comfortable. Coming out of that position feels so uncomfortable to that tissue.
And breathing exercise for the abdomen.
Yep, you got it, 100%.
And also what I know about scars and energy flow, so it's disrupt the energy flow in the body, and that's very important, how we feel on the top and the bottom, or below or above the scars. So everything gets disrupted, and it's very important to reestablish everything, that how it's run.
Yep. And then another layer to it too, for the C-section, for the emotional and the energy component. What we always forget when we had a C-section, we always think about the scar, but you don't think about the fact that, and this is a little graphic for anyone, the organs are exposed to air when they're not normally exposed to air. They need to move the organs out, and they take the organs out of the abdominal cavity. They're exposed to air, and now they're impacted with some scarring in that space. So when we did our visceral mobilization course, and you have to experience it because you're a test dummy for your lab partner, and they're your test dummy to try the things out. I was already doing a lot of emotional work. We were doing work on the small intestine, and I had this moment where I flashed back. I was in the OR, and I had this huge emotional response to it, because I never even thought about my organs during all of my process of everything that I had worked on, because I was always working on my scar, and I was always working on the emotional component, and I was always talking about it, but I never worked on the organs that were also traumatized in that process as well. So it was a huge piece for me that when I had that, I just remember having this, wow, oh my gosh, there's so much more deep rooted into all of this process of how my body is processing and handling it too.
It's like a somatic release, working on the visceral organs, right? Releasing the trauma, physical trauma or emotional trauma. And we know that emotions related to different organs in the body. So when we work on the organs, visceral or with hands, right? It can release a lot of different deep trauma. So when people would like to work on pelvic floor issues, how they can find appropriate practitioners for that?
So pelvic rehab, there's a website that they have. You can easily go on there and you can find a practitioner that's taken the coursework to be able to do internal work. That is ideally what you're looking for. There's a lot of times people who say, oh, I'm a pelvic floor PT, or I'm a pelvic floor specialist of some sort, whatever it is. You really want to make sure that they have the credentials in the background for that, because when I go through PT school, for example, I needed to take additional coursework outside of school in order to know how the pelvic floor is. Like, what are the organs? What are the individual muscles? Because we get those things when we're in class, but you're not taught how to do an internal until you go to that coursework.
Like specialization.
Correct. Like, I couldn't do visceral mobilization until I take one of those courseworks. Same thing for pelvic floor PT. It's a huge buzz, so a lot of people are kind of jumping onto it, but you really want to make sure you're with a practitioner that's taken the coursework, understands, and has been working with people for a while to know, okay, what's going to be safe for you? Should we be doing internal right now? Should we be doing other aspects of things? How are we going to get the right plan of care for you? So really, really important to make sure you're doing your research, but pelvic rehab is definitely one of the spots that you can look at that.
And if people are local, how they can find you?
Through our website, themovementparadigm.com. That's the easiest way to kind of get a hold of us. You can see all of our services that we have. We do pelvic floor, but I also treat a lot of other conditions as well, vestibular, because that's a big piece, and chronic pain, so low back pain, just shoulder pain, all those different types of things. And then we also have functional medicine at our facility as well. Our booking to be able to do a 15-minute discovery session with me is located on that website as well. We do it virtual, either phone or through Zoom, and we just talk about where you are in your journey, what you've experienced, who you've been to, and then I can just talk about how my approach would be for you, and then you decide if it's the right fit for you or not, and then we can schedule from that appointment as well.
Great. It's a lot of great information we had today.
Yeah.
Thank you for coming.
Thank you so much for having me. This was awesome. Really loved to be able to share it, and questions were great. Absolutely loved it.
Thank you, Dr. Becky.
Yeah, thank you so much.
We are so excited today to share with you one of our favorite new products to help your skin optimize. Discover the next generation of skincare with Civ Biome Balancing Serum, a groundbreaking spore-based formula designed to harmonize your unique skin microbiome. Powered by advanced quorum sensing technology, this innovative serum restores balance and promotes resilience from within, adapting to your skin's natural biology for a healthier, more resilient barrier. By establishing a strong, balanced foundation, it revitalizes your skin and enhances its natural beauty. Experience the power and harmony with your skin and transform your routine with Civ Biome Balancing Serum. Available at sivcare.com, civcare.com. Are you ready for your Energy for Life bioenergetic nest scan? Dr. Larisa Sharipova and myself, Priscilla Koblentz, offer personal, private, 90-minute consults to get you back to optimal health and well-being. And starting in the new year, we're offering an Energy Mastery Program, a monthly membership which will give you access to a monthly scan as well as 2 group masterclasses to help you optimize your wellness in the new year. For more details, visit the show notes or check out harmonicalignment.co. We hope you enjoyed today's episode of Harmonic Alignment. If something resonated with you, we would love to hear about it. Please consider leaving us a 5-star review and subscribing so you don't miss an upcoming episode. Thank you. The information contained in this podcast is provided for informational purposes only and not intended for the purpose of diagnosing, treating, curing, or preventing any disease. Before using any products referenced on the podcast, consult with your healthcare provider. Carefully read all labels and directions. The products and information received through the podcast should not be used to replace a consultation or advice from your healthcare provider. If you suspect you have a medical problem or have any healthcare questions, please promptly call your healthcare provider. This podcast, including Dr. Larisa Sharipova and Priscilla Koblenz and the producers, are not responsible for any possible adverse effects from the use of information contained in this podcast. This podcast may contain endorsements and advertisements for products or services. Individuals on this podcast may have a direct financial benefit to the product or services referenced.